Okay, now that we've reviewed the prompt program in respiratory distress, we're going to just do a physical respiratory assessment. We're going to go through basic signs and symptoms of respiratory distress. So, any questions? Okay. No? All right. So the first thing you want to do when you come in and you're looking for somebody in respiratory distress, you want to assess their posture. So in this position, he's in a tripod position, so he's trying to give his intercostal muscles a rest, trying to support them. This is actually a sign of respiratory distress, as well as pursed lip breathing. And in an infant, you may have that nasal flaring that we talked about in the presentation. One of the things you want to do is ask the patient to say something and see if he can talk in complete sentences. If he's having to pause to complete a sentence, that's another sign of respiratory distress. If he is confused, that's really problematic, because now he has a lack of oxygen to his brain, causing decreased sensorium. So that's almost, you need to get somebody to address that immediately. But anyway, we're just looking at assessing these patients for respiratory distress and decompensation while they're in the waiting room. So he looks like he might be having some difficulties, because when he came in, he was sitting upright, he was talking to everybody, and now he's assumed this posture. So this would be somebody that I would want to go over to and find out a little bit more what was going on with him. So, hello, Derek, how are you feeling? You're feeling okay? All right, tell me about your breathing right now. You're having more difficulty breathing. Okay, while I rest my hand on his shoulder, I'm going to be counting his respirations. I'm also going to be asking somebody to get me a pulse ox. There's lots of them here in the office, and we're going to check his heart rate and his pulse oximetry. I'm going to be talking to him, and he's going to be, right now he's alert and oriented. He's giving me the evil eye. That's what you get for working with your kids. But and so we're going to so we've looked at his posture, we've looked at his breathing, we've assessed his respiratory rate and his heart rate and his pulse ox. If any of these things are out of whack, the first thing you're going to do is you're going to go and send for the person on the prompt team so that they can come out and do a complete physical assessment on this patient. It's at that point. You're not going to leave the patient, but you're going to stay with the patient, because when these people get into respiratory distress, it's very difficult to breathe. They get very anxious, and that starts that cycle. Anxiety makes it more difficult to breathe. More difficult to breathe brings more anxiety. It just exacerbates the whole situation. So you want to stay with these people, and you want to try and keep them calm and relaxed until the professional nurse or respiratory therapist can come over and give an assessment. Okay. Now that's decompensation while they're sitting here in a waiting room. I want everybody to be thinking about when these people check in. When they initially check in, you want to be assessing them as well. If they're coming in on oxygen, you want to note that. Do they have any of the circumoral cyanosis, the blue lips, the blue fingertips? Some people kind of stay like that. A lot of these patients in the practice are very compromised. A lot of them will live in this posture at home, spend a lot of time in that tripod position at home. But I want you to engage them when they come in. I want you to note think about whether they can complete sentences, how distressed do they look. You know, it's better off to call the prompt team if you suspect that somebody is in respiratory distress than not to. It only takes a minute for them to come out, real quick assessment. They'll be able to determine whether the patient needs to be brought back immediately and provided treatment. Hopefully there's a room available for these patients at that time. Okay, now we're going to go through some basic respiratory assessments. Sit up for me. Okay, as you can see, well, I don't know if you can see with the lighting that's going on in the room, but on a basic respiratory assessment, You want to again note the posture, you want to note their breathing, you want to see if they're using any intercostal muscles, any accessory muscles to help them breathe. You want to, of course, I've always asked your history questions prior to coming in and doing the examination. Are you having problems breathing, going through their respiratory drugs, or actually all of their medications? But when you start the assessment, you want to do just a quick visual. Then you want to do a palpation. So you want to sit up for me, and what you want to do is, this is the jugular notch here, and it goes down into the mandibrium and the sternum. Here at the sternal angle, if you come across here where there's a notch in the sternum, that's the sternal angle. If you go right across, that's going to be your second rib, and just below that is your second intercostal space. It's at this point in the chest that the trachea that they actually bifurcate into the right and left bronchus. It's also here that you have the top of the apex of the heart. Okay, so you want to do some palpations. You want to feel for any sub-Q emphysema, which would feel like kind of like Rice Krispies under the skin. You want to feel for anything unusual, any lumps under the armpits. You may find swollen lymph nodes. And it's at this point that we want to have the patient say, we're going to do tactile fremitus. We want the patient to say 99. Say 99.
99.
Again.
99. 99. 99. 99. 99.
And you can hear that vibration bilaterally, and it becomes the significance is when it's not uniform. If you have an area of dullness, that may indicate atelectasis or consolidation. Okay, the next thing you want to do after you do a palpation, let me just make sure I'm not missing anything. You want to percuss. If you found an area of consolidation, or you had maybe it was not symmetrical, you may want to percuss, and you want to use 2 taps, and you want to remove it quickly, but you can feel, and if you feel any dullness, that may indicate an area of consolidation as well. Then you want to do an auscultation. You want to listen to their lungs. You want to start anteriorly. If you're doing this anteriorly, look up, sweetheart. You want to start at the apex of their heart, which is actually above the clavicle here. And then you want to do a stair step or a ladder approach, and you want to assess each side of the lungs. The front of the chest is going to have the upper lobes, and the right upper lobe, right middle lobe. And on the left side, you're going to have the left upper lobe predominantly. The posterior of the back is where you're going to hear the lower lobes. In the mid-axillary line on the right, you're going to hear middle lobe and lower lobe. And what you're going to be listening for, excuse me, lean back. You're going to start up here and listen to the apex, and you're going to have them take a deep breath, in and out. And you're going to do that ladder approach all the way down. Now if your patient, again, okay, and you're going to make sure that you check those mid-axillary lines. Now, if the patient becomes short of breath during the exam, you want to make sure that you pause and let him catch his breath, because some of these patients are not able to take all those deep breaths necessary to fully assess their respiratory status. Okay, so then you're going to do the same thing to the back. If you have your patient bend your head down, you're going to feel this notch here, and that's T1 and C7, and that's going to be the beginning of your thoracic column. And you're not going to be able to hear anything over the scapula, so you're going to do a stair-stepping approach with the stethoscope, right to left, all the way down until you come to the bases, comparing the breath sounds on each side. Now, what might you hear? I think I know that everybody in the office listens to breath sounds regularly. I know that you know what crackles are, rhonchi, stridor. Stridor, if you're hearing stridor, especially in the upper airways, you need to get the physician in to take a look at that. I just lost my train of thought. My train of thought left without me. Okay. All right, so let's recap let's just recap of respiratory distress. Would be a patient that's starting to decompensate. And remember, a lot of these patients in this practice are very compromised. Some of them live in a certain degree of respiratory distress. A lot of them are end-stage COPD, a lot of them, and other issues that will cause them to be constantly compromised. So it doesn't take much for those patients that are compromised to become in distress very quickly. So what we're going to do is we're going to look at those patients on check-in. We're going to look at the patients in the waiting room, and we're going to do a visual survey every time we enter the waiting room. And we're going to be looking for those signs and symptoms of respiratory distress, that posturing, that inability to speak, the change in sensorium, the rapid respirations. And at that point, you're going to get a pulse ox and you notify the prompt team so that they can come out and they can have a professional assessment done at that time and make some critical decisions of whether to move the patient in the back if a room is available or to get the doctor out and see the patient immediately. Okay, so again, our respiratory assessment, we first do a visual assessment. Well, we actually start with asking questions about his respiratory status, how he's been doing, assuming all of the history has been taken. When we actually get down to do our physical assessment, it's going to be, we're going to do a visual first, we're going to do a palpation, we're going to do auscultation, we're going to note any changes to breath sounds, any adventitious breath sounds. Over the bronchus here, you're going to hear bronchial breath sounds, then it's going to be bronchial vesicular, and then you're going to hear vesicular breath sounds over the majority of the lung fields. If you start to hear, if you're hearing crackles, which sound, some people say it sounds like hair being twisted between your fingers, that's a sign that there may be atelectatic changes, there may be pulmonary edema taking place. Wheezing is a high-pitched sound. It could be inspiratory or expiratory. And the one thing you want to pay attention to, especially with wheezing, is if they're wheezing loudly and suddenly they stop. You know, and the wheeze, they can get very tight very quick. We want to get those patients on some bronchodilators. We want to get them some oxygen. That can turn into an emergency pretty quickly. Any questions? Any questions on the prompt program? Okay, have a good night. I hope that covered my assignment. Thank you.